I'm sorry, I don't speak Spanish, so English or Italian. You tell me which one is the best. English? Okay. My English is quite easy. So, autofluorescence is a new tool for knowing the situation of the retinal pigment epithelium cells. And it's easy to take, it's not invasive, as you heard just now. And I will try to show you all the possibility that you can have when you deal with autofluorescence. Please, in any moment, you can interrupt me, and if I have to clarify, let me know. So this is just a drawing, simple drawing of retina, and you have, choroid, all the layer for Brooks membrane here, and the RPE cells, and these are the photoreceptors and all the other neurosensory retina layers. And here is the macro pigment. It's drawing like that because it's quite important in the autofluorescent image. Now, what are these yellow dots? These yellow dots are lipofuscin. And autofluorescence, it comes from lipofuscin. You know what is a fluorescence, first of all. If you use a light, you create another light at a longer wavelength, it gives some information. So if you take, and the difference between reflection image and autofluorescent image is that when you have a reflection image, a red-free image, for example, you take the light and you record the light that comes back from what is reflected by your layer. With autofluorescent, you project a light, and this light creates another light that comes and gives you an image. So it's not the same light that you project, but it's another light. So the difference is that you have one way for autofluorescence or all fluorescence image, and you have two lines for reflective image. Okay, so what is lipofuscin? Lipofuscin is this is a specimen where you see the Brooks membrane taken with a fluorescent microscope. And here are all the granules that are inside the RPE cells, and these are lipofuscin. Lipofuscin is, and actually it's increased with age. Instead, in fact, you can say that the more you grow, the more you glow, because the fluorescence is increasing with age. This is a flat mountain of RPE cells. You see melanin inside. It's higher also in young people, but not in old people. And you see that there is more fluorescent here, but not here. You know how lipofuscin is created. There are two ways. One is the shedding of a photoreceptor. You know that every RPE cells eat 7,500 discs every day. And so you can imagine that during life, it can be that not all the discs are completely digested. And what is not digested creates lipofuscin. So it's the shedding, but it's the eating of the disc, and then you have the lysosome and the disc that try to digest. When it's not digested completely, you create lipofuscin. The other possibility is the degeneration of melanin granules that can be create not exactly lipofuscin, but melanolipofuscin. And we will see some images that underline the Milano lipofuscin. So, but at the end, you have all the lipofuscin granules. Why lipofuscin can be important? Well, you know that if you have a visual cycle, you create more shedding and more, some substance that is in the lipofuscin, that is the A2E, that is the toxic part of, or at least the known toxic part of lipofuscin. So, by itself, lipofuscin inside the cells is creating damage to the cells. And one of the theory of age-related macular degeneration is related to the increasing lipofuscin. In particular for atrophic or geographic atrophy in age-related macular degeneration is related to the accumulation of lipofuscin. So there are some different experiments on the RP cells full of lipofuscin or without lipofuscin. If you put the blue light, all the cells with lipofuscin die in few hours, without can stay longer. And it seems that blue light interact with lipofuscin, activating the A2E. Now, as you can imagine, if you see more, you have more production of A2E. So one of the idea that introduce new drug for geographic atrophy is to reduce the production of A2E. So what you can do? First of all, don't give vitamin A. Vitamin A is a precursor of retinol. So if you increase the visual cycle, you increase the production of A2E, and you can increase the accumulation of lipofuscin and the death of cells, so the atrophy can increase. And so in fact there are two drugs that are under trial right now. One is isotretinoin, is the one that you use for acne, and is working on 11-cis retinol. It's stopping this, so it's blocking the visual cycle. And the other one is a difficult name that I usually don't remember. It's flea something, sorry. And it's acting on the absorption from the blood stream of vitamin A at this level. So both create a decrease in visual cycle, and for the patient can act reducing the capacity to see at night. But it seems that decreasing the E2E can decrease the evolution of geographic atrophy. This is a theory, and it's tried to be proven with these two trials that are running almost completely now. So we actually have an idea, taking an autofluorescent image, how the RP cells are sick or not. Now, what can, and it's easy to get, because a user has an excitation light, a 488 nanometer wavelength. That is the one that you use for fluorescent angiography, exactly the same. And you use as a barrier filter a wavelength that is about 500 nanometer. So is exactly the same that we use for fluorescein angiography. So practically, if you take a filter excitation and barrier for fluorescein, you get an autofluorescent image. Now, it's a little bit more complicated in some way because there are more different types of autofluorescent image. So right now we like to call the 488 autofluorescent, that is this one. Then we have the near-infrared autofluorescent, that is exactly the one that you can get using the ICG filters, excitation and barrier filters. And then there is the autofluorescent images that are taken from the Topcon or the Zeiss cameras that are completely different. They are between the 488, so the blue light, and the near-infrared. It's about, I will show you later the example. This actually is a Topcon, the early Topcon autofluorescent. Now, this was done by Spade, but I will show you some strange situation. Now, if we accept the idea that we collect the fluorescence that comes from the RPE cells, we can see just some homogeneous fluorescence if the RPE is intact. If there is a lack of RPE, we will see fluorescence that comes from behind. Now, if you look carefully, this is an infrared image, and you can imagine that the infrared image can go through the RPE, and so you can visualize all the choroidal vessels. Now, I would not expect to see in an autofluorescent image choroidal vessels, like here, for example, these two. This one is visible also here. So it means that at least we are not collecting the fluorescence that comes only from the RPE, or that this filter has leakage. Do you know what means leakage in filters? I try to explain. If you have a barrier filter that allowed some lights to come in, in and out, and the excitation filter, if they are not overlapping, are fine. If they are overlapping, this is a leakage. It means that you take some image that comes from the reflecting lights and not only from the fluorescent light. I was clear enough? So it's impossible to see some choroidal vessel if there is no leakage. Because here we have some reflective light from infrared that comes and interfere with the fluorescent image. In fact, if you take a confocal laser ophthalmoscope where we use a very narrow light, it means it's created by laser, so 488 plus minus 1 nanometer. Here you see a white light with a filter, so it can be a broader band. And you see that here we see the choroidal fluorescence here, but just because we are in the middle of a geographic atrophy, there is no RPE cells anymore. If you look at a normal area where RPE cells is there, you don't see a choroidal vasculature. And that's what I expect from a autofluorescent image that image only the RPE cells. Okay? And these are the Topcon filters. You see, instead of 488, the excitation is about 580, and about 700 is the barrier filter instead of 500. So it's a little bit more in advance. Now they changed something, and we are evaluating the Zeiss camera that has a filter like that, and you don't see the choroidal vasculature. So it means that the paper published by Spade was a little bit weak in deciding exactly the filter for taking in images. Just to give you the idea of what you have with the scanning laser ophthalmoscope, 488 and 520. Okay, now the macro pigment is here, and why it's important. You see an autofluorescent image here, and you see a dark spot here, or at least a darker spot. That is due to macro pigment, because we say it's a yellow pigment. So if we use a blue light is absorbed by yellow. So you cannot have neither way, in and out, a light that comes from that center point because of the yellow pigment. So indirectly you can actually see how much extension you have in macular pigment, and in fact there is a study that I did with Francois Delory in Boston that show that there is a difference between male and female in the distribution of macular pigment. It's not clear why, but you have an annular increase of fluorescence in female and not in male. There are some theories about the anatomy.
That is female?
With a male. Yes, I think I have some example. I will show you the different. Let me see if I can catch immediately. Yes. You see this, the annular either autofluorescent here, that is a female. And these are males, and here there is almost no macropigment. An interesting situation is in juxtafoveal telangiectasia, the 2A by definition of gas, and both patient has no macular pigment. It's not clear yet why, but it's okay. Go back to. Okay, so the macular pigment is here, it's black, and this is white. You know, the yellow pigment, if you put some blue light, you see that it's absorbed. This is in monkeys, but humans are quite similar. so this is why you have a black spot. Now, what else can interfere in taking an autofluorescent image? And it's quite important to know because after that you can do a differential diagnosis. So, the photoreceptor pigment, for example. You know that we say the visual cycle is creating a photoreceptor pigment. And we adapt to the light, with bleach, we destroyed all the photopigment. If you put the patient in a dark room, they rebuild the photoreceptor pigment. For sure, if I project a light in your eyes, and after some time you see an after image. The after image is due to the fact that we bleach all the photopigment, and it takes some time to recover. So in old people, it takes more time than a young subject. If I project a light from a bulb, a normal light, yes, you see some lines that are actually what inside in the bulb, and it means that we project that light and we burn all the photopigment in that area. And we'll show you some images that we saw this morning and yesterday. So, here's the difference. So, do you know which is the difference between this darker area and this bright area? Dark adaptant and light adaptant. So here there is a photopigment, still photopigment, and so we interfere with the fluorescence that comes from the RP. The photopigment is in front of that. So we have the RP cells that give the fluorescence, and over it there is a photopigment. If we bleach, we see more fluorescence that comes from the RP. If it's not, it's dim a little bit. So, and even more evident, if you move from 20 degrees image to a 30-degree image, you see the two, darker area of the 30 degrees, but if you wait just a few seconds, you see it's everything is bleached. And that is quite interesting because it can help to explain some pathology. And if we will have time, it's a little bit more difficult, so I will go step by step, and if we have time, I will show you some cases where it's important to know. But we can actually measure the photopigment, and with a normal instrument, just to give you an idea, to measure a photopigment until now was used a unique machine that are in the lab. You can do a photo, a psychophysical test, or a more difficult test with reflection imaging, but usually are just possible in a few centers in the world. Using a commercial machine and using the autofluorescent, you can actually measure photopigment. So, first of all, you take an autofluorescent to know the noise of the camera. Then you dark adapt it for 20 minutes per patient. So then you align the eye, so you exactly know where you are taking the image with an infrared not bleaching the photopigment. Then we take immediately a first autofluorescent, so in dark adapted. Then we took for 5 minutes in front of the instrument with the lights on the patient, and then we take the other autofluorescent image and in light adapted. And then we got with software some images like that. This is a differential image between one and the other, or with a software done by Heidelberg for measuring the photopigment, but when it's a different story. Sorry, the macropigment. You can actually have a map of the photopigment. What else can interfere with the autofluorescent image? Blood. But where? The intraretinal blood. Because the subretinal blood cannot interfere because the fluorescence comes over the blood. And that is important because when you look at the color picture, you see blood, and you don't